For the next session, on plenary session, I would like to take the honor to invite the chairpersons and the judges on the stage. Dr. P.N. Rao, Dr. Subrat K. Acharya, Dr. Shiv K. Sareen, Dr. Yogesh Chawla, and Dr. Rakesh Agarwal. The scoring sheet has already been provided.
Many thanks, and I think this is going to be very, very interesting. And then here we are going to have many original research publications from our candidates. And the first one, may I invite Dr. Akhilesh? Yes. And for this topic is that low volume plasma exchange to treat 360 rodenticide hepatotoxicity patients across the public and private sector hospitals in the Tamil Nadu. I think this got a lot of a public health importance. Please go ahead.
Good morning. I'm Dr. Akhilesh. I'm from CMC Vellore. Today I'm presenting a study, low volume plasma exchange to treat 360 rodenticide hepatotoxicity patients across both public and private sector hospitals in Tamil Nadu. Background: rodenticide ingestion is an important cause of hepatotoxicity and subsequent acute liver failure in South India. The prognosis of patients managed with only supportive management is poor, with a majority of them unable to access urgent liver transplant when required. Plasma exchange has proved to be an effective mode for survival to improve the native liver survival in rodenticide hepatotoxicity, but however, the prior studies had small numbers. Our study evaluates the impact of plasma exchange in rodenticide hepatotoxicity in a large cohort from 2 centers. Methodology: it is a retrospective study involving 2 centers, namely CMC Vellore and Coimbatore Medical College. Timelines for data collection varied between Vellore, wherein the data was collected from 2017 to 2024, and Coimbatore, wherein the data was collected from 2022 to 2024. Patients who had a diagnosis of rodenticide hepatotoxicity and underwent low volume plex were included in our study. Those who had rodenticide hepatotoxicity and who did not receive plex were excluded. The plex protocol was 11.5 French dual lumen high flow venous catheter with femoral access was used. In those patients who had large peripheral veins, peripheral access was tried. The volume was half the calculated plasma volume as per Kaplan's formula. 3 sessions were done, and the target was 3 sessions, but it was titrated as per the treating physician. Preferential centrifugal plex was the technique used. Low dose steroids and prophylactic antibiotics were started at least a day prior to plex. Shock was defined as hypotension receiving vasopressors. We used standard definitions for our 3 syndromes as per INASL, that is uncomplicated hepatitis, acute liver injury, and acute liver failure. And we used Kochi criteria and King's College Hospital criteria, ALF non-paracetamol criteria for the severity or stratifying the severity of our patients. Kochi criteria is specific for rodenticide, wherein in the index study, patients with MEL greater than 36 or an INR of greater than 6 with hepatic encephalopathy warranted urgent liver transplant, and the survival was 0 when they did not undergo liver transplant. Statistical analysis: continuous variables were expressed as mean for normally distributed data and median when the data was skewed. Categorical variables were expressed as frequencies and percentages. Univariate analysis was done for various parameters on survival, and a p-value of 0.05 was considered statistically significant. Receiver operator curve analysis was done for evaluating the diagnostic accuracy of delta MELD on survival with a 95% confidence interval. SPSS version 29 was used for data analysis. Coming to our results, 360 patients were included in our study, of which Coimbatore contributed 230 and Vellore contributed 130. The mean age was 28. 61% of our study were males. And the compound ingested was yellow phosphorus in 98% of patients. As you can see, the later the patient presented, the more severe the syndrome was. Days from ingestion to plex was 6 days for ALF patients as compared to only 4 days for uncomplicated hepatitis and acute liver injury patients. The preplex bilirubin, INR, creatinine were 4, 2.36 and 1. The preplex MELD of 22. Coming to our syndromes, uncomplicated hepatitis, 18% of patients had a preplex syndrome, uncomplicated hepatitis, 35% had acute liver injury, and 46.4% had acute liver failure. Coming to the severity stratification, 33% of our ALF patients fit into King's College Hospital criteria for ALF patients, and 20% fit into Kochi criteria. So 82% of patients underwent centrifugal plex, 71% of patients received steroids, which was prednisolone was the preferential steroid used in the Vellore cohort, whereas dexamethasone was the steroid used preferentially in the Coimbatore Medical College cohort. Coming to our overall survival, 67.3% of patients survived of the 360 patients, and the survival according to syndrome was 91% of patients survived who had a preplex syndrome of uncomplicated hepatitis, 79.3% had ALI survived, and 49.1% was the survival with ALF. Those patients who satisfied Kochi criteria had a 38% survival, and those patients who satisfied King's College Hospital criteria for ALF patients had 31% survival. Patients with shock requiring vasopressors had poor survival, as the survival was only 32% in those who had shock against an overall survival of 67%. In ALF patients, the survival was only 28% in those with shock, as against 49% overall. Hemodynamically stable patients had better outcomes. In Kochi criteria, once we exclude the patients with shock, the survival improves to 51%, as against the overall Kochi criteria satisfying patients, the survival was 38%. In King's College Hospital criteria, the survival improved to 42.3% as against 31% when those patients with shock was included. Used univariate analysis for survival as comparing between the alive and dead patients. The preplex bilirubin, INR, and creatinine were significantly different as compared to the in alive. It was far better as compared to those patients who were dead. The delta MELD, that is the difference between the first and the last session of plex, improved in the alive patients by 17 points, whereas it worsened by 22 points in the dead cohort. Plex showed a decline in MELD from 22 to 17 in a cohort, and the decline in MELD was 22.7. We used an area under the curve for designing a model for survival of delta MELD, and the area under the curve was 0.69. Among the 128 patients, so we had a Sankey diagram for plotting the progression of the syndrome during hospital stay with a 3 syndrome: uncomplicated hepatitis, acute liver injury, and acute liver failure. Among the 128 patients who had acute liver injury prior to plex, in those who did not progress, the survival was excellent, 93%. A discussion. We are able to salvage a significant proportion of ALF patients with low volume plex. Patients with shock fared poorly. In view of the rampant hepatotoxicity due to rodenticide in Tamil Nadu, the state of Tamil Nadu has established a referral chain, popularly known as the hub and spoke model, to address this rampant prevailing hepatotoxicity, and our study indirectly portrays the success of this model. Historically, patients satisfying Kochi and King's College Hospital criteria warranted urgent liver transplantation, but we are able to salvage a significant proportion of them. As per the initial study, in the 22 patients, of which those who did not undergo liver transplant, all of them died. In our study, we were able to salvage 38% and 51% when shock was excluded. In King's College Hospital criteria also, as per the initial study, there was only 3% net liver survival. In our study, there was 31% and 42% when patients with shock were excluded. Our study had a large sample size, and it had both public and private collaboration involving 2 centers. It was a retrospective study, and a lack of a control arm were the limitations of our study. So from a study, we were able to conclude that we are able to salvage a significant proportion of ALF patients with low volume plex. ALF without shock had improved outcomes in our study. Thank you.
Thank you, thank you, thank you, Dr. Akhilesh.
Yes.
Even though you don't, is the retrospective study is a wonderful in terms of a public health, but do we have any large previously already cases? The report published data on this issue. There
On
must be. There may not be any comparative arm, but there must be some published data on the without any this kind of a management, therapeutic
on
management.
rodenticide, sir.
Yeah, the rodenticide.
The previous studies in we have done studies by Lena Thomas et al. And Alexander et al. For rodenticide, and they were able to show significant improvement with plasma exchange, sir.
No, what he's asking,
Yes, sir.
young man, that it's very difficult to say whether low volume plasma exchange in this rodenticide group, which you have tried, has improved survival because you don't have a comparator arm. Second, what he's trying to say, your predictive scores for bad outcome, which is King's College and Kochi criteria, only had 20% and 30% amongst the large group. So about 70 to 80% has simple acute liver injury. Okay. And there is no data which you are showing among this at-risk group for mortality, fulfilling these two criteria, right? There is any comparator arm. It is also, if you would have seen your past retrospective data with similar patient who has bad prognostic model, what is their survivor, and would have presented, then they would have been more convinced. That's what Dr. Rao is asking.
Yeah, that's right.
Am I clear?
Yes, sir. So, sir, I agree we didn't have a standard medical treatment arm. But when I worked in MD or in post MBBS, I have seen that those patients with rodenticide, we were unable to do anything. That is, they invariably died. So now our survival has improved with Plex. We are trying to get a standard medical arm using retrospective data, and we are trying to assess the improvement in survival with that.
Professor Mishra.
Sir, about this control, it will be unethical to have a control arm now because they have shown that it works. My question is, it affects the endoplasmic reticulum mitochondrial function. So the entire body will be affected. Did you see for kidney injury? Did you see for cardiac injury? And if the two were there, was the mortality higher in these patients? We're only talking about the liver.
Yes, sir.
No, what about the kidneys and the entire
Yes, sir.
patient is the patient.
Yes, sir. So rodenticide, yellow phosphorus is a protoplasmic toxin wherein it has multi-organ damage. We have seen patients with acute kidney injury also, and we have, yes, sir, we have, but I have not put up the results for that.
I think the last.
And in cardiac toxicity also we have seen, and one of our patients in uncomplicated hepatitis also who has died also is probably because of cardiotoxicity is why the patient has died, because even with not very severe liver injury, that patient had cardiotoxicity, and that was one postulated reason why that patient had expired.
I think the last two, one by Dr. Professor Anand and by Dr. Agarwal, then we will conclude, please.
Okay. Which KCH criteria have you used? The paracetamol one or the viral hepatitis one?
Sir, I have used the non-paracetamol criteria.
So, I don't think this study has shown anything that ethically challenges the concept of a trial in future. This could have happened, what we saw the results could have been because of, irrespective of, or in spite of Plex. So I don't think anything, this precludes any further trial.
Thank you. Thank you, sir.
The next Presenter is Dr. Gaurav Tripathi. He will present circulating fungal microbiome mediated lipid dysregulation induces mitochondrial dysfunction and shock in critically ill alcohol associated cirrhosis. The study is from ILBS. Please go ahead.
Good morning, everyone. First, I would like to thank you, the organizing committee, to give me this opportunity to present. My work is entitled as Circulating Fungal Microbiome Mediated Lipid Dysregulation Induces Mitochondrial Dysfunction and Shock in Critically Ill Alcohol Associated Cirrhosis Patients. So, we declared no conflict of interest. Now, for the introduction part, critically ill patients, especially those with ALD, often show disrupted lipid metabolism and altered immune responses. Invasive bacterial and fungal infections are increasingly recognized in these patients due to gut dysbiosis and immune dysfunction. The role of circulating fungal microbiome and associated lipidome in driving systematic inflammation, clinical deterioration, and outcomes remains poorly understood. So we hypothesize that the interplay between fungal translocation and lipid imbalance drives organ dysfunction, leading to shock and poor clinical outcome in patients with alcohol-associated cirrhosis. Now, for the study design, we have enrolled 50 healthy controls, 50 alcoholic cirrhosis with no infection, and alcoholic cirrhosis patient with sepsis or shock. We got 36 sepsis in discovery cohort, 64 shock, which were again recategorized as survivor and non-survivor. We did plasma lipidomics analysis, plasma fungus analysis, and stool fungus analysis. We validated the biomarkers we received in an independent validation cohort. In total, this study comprises of around 400 patients. We also found the diversity association and proteomics profiling for understanding the fungal surveillance. So the key questions of the study was to identify clinical indicators of shock, to understand the role of fungus, its growth and role in disease progression, to understand lipid dynamics in sepsis progression, to identify host fungus lipid axis that can contribute to shock progression, and finally, how fungus can grow inside human body, even if we have an immune system. So the clinical parameters were comparable. The total lipid pools decreased as the patient progresses towards shock and sepsis, and we also we also took lactate and noret levels, and they were significantly different. So first, starting with the plasma and stool diversity, so the genus distribution of the fungus in plasma and stool was distinct, and the diversity of fungus decreases when the patient progresses from sepsis to shock, but the highest was observed in sepsis group. Now, so in general, we compiled both the species that was upregulated in both plasma and stool, and we found these species, which includes Yarroaya, a very much species of Aspergillus and Cryptococcus and Candida. Among them, we selected the top 5 species, which were Aspergillus flavus, Aspergillus niger, Candida albicans, Cryptococcus neoforms, and Yarroaya lipolytica, which shows the most number of peptides of in the patients. Also, the pathways with these proteins of the fungus B peptide were associated with more fatty acid degradation, fatty acid metabolism. So next, we identified the lipid signatures in the circulation, and we found that the total lipid content pool in the patient decreases as the patient progresses from sepsis to septic shock. The major class distribution of lipids has been changed. The levels of, for example, glycerophospholipids has increased, while the level of sphingolipids has been drastically decreased, suggesting the role of these lipids in the progression. If you see the heat map that is presented on the green and yellow spectrum, you see the green shows down regulation while the yellow shows up regulation. So if you see the patient, so these are the major classes of the lipids we identified in the plasma, and you see that most of the classes, apart from 7 or 8 classes which were up in these patients, most of the classes have shown acute down regulation. So then we compared the shock with the alcoholic cirrhosis non-infection counterpart and shock with the sepsis counterpart, and we identified the lipids which was expressed specifically in the case of shock. This includes 5 lipids which has been used to construct a probability of detection model, in which the 2,5-dihydro-D-gluconic acid, which is a microbial metabolite, probably morely on fungal origin as well, showed highest upregulation with an AUC of 0.86. Then we also compared the levels of these biomarkers in the survivor status of the patient, and we identified, yes, again, 2,5-dihydro-D-gluconic acid and associated lipids again popped up as biomarker for mortality as well. So next we compared, all the POD models that has been constructed earlierly in the study was compared to the known clinical scores, for example, SOFA, ARC, and others, and we found that our score of POD non-survivor lipids outperformed every other score. So we again do the Kaplan-Meier estimation, and we found that the model having a value of more than 5.25 basically predicts both shock and mortality. So till the findings, to summarize here, that we got high growth of fungus in shock patients, an increased level of Aspergillus flavus niger, Candida albicans, Cryptococcus neoforms, and Yersinia in shock patient. So the question that came up in our mind is that how these fungus can grow in the patient and how it changes the host metabolism. Next, we identified there was decreased fungal diversity and lipid diversity, but high fungus levels and low lipid levels. So where does the lipids go and how does the fungus grows? Then accumulation of oxidant lipids, so what oxidant lipids do and where they come from. And finally, we found that mortality and shock were associated to nearly same kinds of lipids and fungus. So we want to validate in a larger cohort. So first we validated them into an independent validation cohort, and we used two approaches, the traditional statistics and then the ML-based validation. We constructed 24 models and are altogether modeled with random forest performed best. Then next was question how fungus grow and what they do. So we checked the expression of fungal surveillance protein in the plasma, and we found that proteins like SCARB1 and SELECT4G, which is potentially identifying fungus carbohydrate moieties as an identification, were hugely downregulated in the shock patients. So the immune system in shock patients are not able to identify fungal component that is coming in circulation. Then we identified the expressions of lipid transporters, which are very critical for managing the lipid host lipid metabolism, and they were acutely downregulated in all the patients of shock. We also found increased expression of PPARGC1, which is a regulator of glycolysis and beta oxidation, and we found that the beta oxidation was high in shock patient relative to the non-shock counterpart. We also checked the levels of oxidative stress and mitochondrial response protein, and if you can see that shock patients have very high oxidative stress response and mitochondrial response protein. So now, to summarize of my study, so first we found that the patient with shock had high fungal growth, and if you see these species are known to thrive on lipids, host lipids. So if you see when these, because we have a low expression of fungal surveillance protein, this fungus can come in circulation, and this fungus basically have higher expression in non-survivors and shock patients. These fungus are known to thrive on patient lipids, thus they can utilize host lipids and make it basically brings the host lipids level 2 down, which can basically predicts the outcome of the patient. So the total patient lipid pools decreases, which cause hypoepolipoproteinemia also is one of the contributor. Increased beta oxidation is also a big contributor. We got fungal derived lipids which were oxidant in nature and which can basically cause mitochondrial failure, which has been known to be associated a common main cause of shock happening. So in short, what I would say is that the fungal driven hypolipidemia basically cause acute lipid loss in the patients, which ultimately, and the fungal derived lipids which are oxidant in nature causes mitochondrial failure in these patients and is one of the reasons deterioration of shock and organ dysfunction. So for conclusion, we got fungal overgrowth in is linked with dysregulated lipid metabolism and acute hypolipidemia. Lipid biomarkers predict shock and mortality. Fungal species, Aspergillus flavus, Cryptococcus pneumons are enriched in non-survivors. Mitochondrial proteins like DLAT, ACSS2, PPRGC1 were upregulated, indicating oxidative stress. Downregulated lipoproteins suggested impaired lipid transport and immunity. Lipid-based POD model outperformed MELD, SOFA, lactate norid criteria, and APACE for shock prediction. Lipid model score greater than 5.35 were associated with high mortality risk. Also, lipid supplementation may counter immune dysfunction in hypolipidemic AC patient. Plus, the lipid profile test can be a very much important test for predicting the outcomes in these patients. So I want to acknowledge Professor S.K. Sareen, Dr. J.S. Maras, my guide, ILBS and our team. I also want to acknowledge ICMR for funding this work. Thank you very much.
Yeah, Rakesh wants to ask a question. Yeah.
Hi. A lot of data.
Yes, sir.
My question is, how do we say that fungus led to shock? Could it be the other way around, that shock causing tissue ischemia promoted the growth of fungus?
Yes.
Yes, sir, we can say that because not in this study.
Because you took a sample
Yeah.
and fungus was a fungal elements or fungal metabolites were already present, right?
Sir, they were compared to the healthy counterpart and there they were not present. In also non-critical cirrhosis, they were not present.
So how do we say that there is no reverse causation? It is shock that led to fungus, not the other way around.
Sir, we can say like, So in our other studies, like validating your point, we identified that, yeah, immune cells dysfunction and the ability of immune cells not to kill, present pathogen is one of the reason they act as reservoirs for infection somewhere. So I agree with your point in this sense that it might be that presence of shock is causing, fungal infection, rather than I say fungus is causing infection. But this is a study, in which we found that fungal peptides are very much enriched in the plasma, and also the lipids which we identified in the study are oxidant in nature.
No, we cannot say that those lipids are there because of the fungus. You have not shown any data that show that those particular fungi were responsible for those lipid changes.
Sir, sorry, I haven't shown it here, but yeah, we do have that data in which all the lipids like 2,5-dehydrodegluconic acid is known in, what I say, papers with it is fungal in origin, sir.
But don't you think in patients with alcoholic cirrhosis, the lipidemic profile as such per se will be decreased? Because basic lipidem metabolism comes from liver. When there is a severe liver damage, right, the lipidem profile will be decreased. The source may be from the host, the source may be from the infection, but processing is in the liver, right? What you have showed that there is a when there is a high fungal infection, the lipidem profile is low.
Yeah.
When there is a low fungal infection, the lipidem profile is high.
Yes.
Based on that, you have designed a score,
Yes, sir.
and you have predicted a risk and validated that model.
Yes, sir.
This is essentially your study.
Yes, sir.
There's a lot of data, there's a lot of science. But how do you know that liver damage per se is not influencing this? Because in this data, you have a large number of samples.
Yes.
Have you seen in severe liver damage with similar scores, having fungal infection or no fungal infection, is there any difference in lipidemic profiles, whether the model works or not? Did you understand my question?
Yes, sir. Sir, we also, in this study also, we had a non-critical group in which we had no fungal infection and the lipid pools were high.
In critical group with fungal infection, there will be some patient without fungal infection also.
Yeah.
Did you find any difference in lipidemic?
No, sir. Like our population nearly showed homogeneous results.
That's fine. Dr. Mishra.
So my question is similar to Dr. Rakesh Agrawal here.
Yes, sir.
Is it a cause and effect, or is it an epiphenomena that we are finding it? Secondly, how soon after shock did you take the samples? If you take it immediately, probably it may be more useful. If you take it after some days, the shock per se can cause all these problems.
Sir, so we did this work with Dr. Rakhi ma'am, and we collected the sample at the day of
Simple
admission.
question.
Day of
Don't
admission.
beat about the bush. How soon after shock did you take the samples?
Day 1. Admission and post day 1 or maximum day 2, sir. That is the collection time.
Gaurav, Dr. Arun here. Excellent study. One doubt is, what is the fungal culture positivity rate, and how much of it could you attribute to either relic fungus or active fungal infection in your study? Did you do concomitant fungal cultures?
We did.
Yeah.
Around
Thank you.
12% were positive for the culture. Exactly, the culture results are positive for 12% for fungal. We also did galactome and for that.
Hi, very nice omics study. I have two questions for you.
Yeah.
The first question is that you have focused your study on fungal microbiome
Yes.
essentially, but patients in shock
Yeah.
are also susceptible to bacterial infections, and there are multiple organ failures.
Yes.
How have you kind of factored those other factors in when you are looking and interpreting your lipidome profiles? That's my first question.
Okay.
Second question is, you have focused your studies on alcohol related cirrhosis
Yeah.
only.
Yeah.
So what is the reason for your selection of this group, and would it not be better to include the non-alcohol related cirrhosis as a comparator group also in your study?
Okay. So for the first question, I want to answer is that we did look for the bacterial also. So we have a separate study for that in which we have profiled the bacterial population in shock and the metabolites associated to it and lipids associated to it. So we want to see specifically what fungus is doing in shock. So that's why we used.
But the way you've designed your study is not going to answer that question, because you may have focused this particular study on fungus, but you cannot factor out that there will be concomitant bacterial infections, other multiple organ dysfunction, a lot of other things happening in the.
So for omics data is too complicated. So for the sake of understanding that everyone understands, we split the data into bacteria, fungus,
So
and virus.
essentially, your lipidome is an outcome of all these factors combined, not
yeah.
only fungal infections. Okay.
Yeah.
Then
And
second part.
for the second question, yes, I agree. We can include more number of patients of more disease.
So
but,
what was the reason for your selection of this etiology only in your study?
So the right reason was that this is my PhD work, So my PhD was designed on alcoholics. And second, alcohol has been known to induce fungal, prolonged alcohol consumption has been correlated with the, acute fungal infections in the later stages. So that was also one reason.
Okay. Thank you.
Thank you very much.
Sarja, can
I think this is food for thought. What she mentioned, go beyond alcohol.
Okay.
And I was only wondering, all these patients must be on antibiotics. So the type of fungus that you grew, or you had the microbiome, was it commensal or induced?
Sir, we got both kind of fungus, like commensals was also, but the levels were very high. And we also got major drivers were either Aspergillus or Candida and Yarrow. So these were the key species which came up. So we got 4 or 5 species from Aspergillus itself. So I would say Aspergillus was the main threat in this kind of patients. And even after getting
Maybe
antibiotics.
You could factor in the antibiotics that these patients were receiving before they came to you. You could factor that.
Okay, I would do
Dr.
that.
Gaurav,
Yes.
every bench has to transform into some kind of a clinical orientation. Based on your research, is there any biomarker, lipid biomarker, have you found out for an early diagnosis, and any therapeutic benefit from the large work which you have done?
Yes, sir. So, sir, for benefits, the panel that can be easily done on mass spec based setup if you have. So we can do it in 15 to 20 minutes. That takes sample preparation, and 1 hour. A test of 1 hour can be developed from this data because we have validated in a larger cohort. And for the translational benefits, we can use a normal lipid profile on a regular basis to basically identify whether the patient is getting deteriorated more or not. And lipid supplementation would be a very important way of handling these patients. So if we do lipid supplementation, with the sir, we tried these on some patients in the little less severe patients, and we have found a surge of energy in these patients, and they performed well. So supplementing intralipids would be very good approach in these patients.
That is well known clinically because the liver disease lipid profile is very low, and it is recommended lipid. They do well with lipids. But thank you.
Thank you very much, sir. Thank you, everyone.
It's my pleasure to invite Dr. Nipun from PGI to present his work on identification and validation of receptor interacting protein kinase 3 as a biomarker in acutely decompensated cirrhosis for targeted personalized therapy. Nipun, please.
Good morning, everyone, respected judges and audience. I thank INASL and bring greetings from PGI. So we all understand there is an emerging evidence of different forms of cell death in driving the pathobiology, immune dysfunction, organ failures, and mortality in acutely decompensated patients with cirrhosis. Not only apoptosis, non-apoptotic forms, especially necroptosis and pyroptosis, as you can see in this figure, is highly immunogenic, drives the immunobiology, pathophysiology, and outcomes, which is shown elegantly in the recent studies. These non-apoptotic forms are captured through liquid biomarkers such as RIPK3, which is receptor interacting protein kinase 3, or mixed lineage kinase like domain MLKL. And pyroptotic forms are captured by Gas-Dermin D, whereas apoptotic forms are captured through M30, and M65 captures the total cell death. As I said, non-apoptotic forms are increasingly recognized cause of mortality not only in AD and ACLF. Our recent study has shown that these non-apoptotic forms such as RIPK3 and MLKL increases with the increasing progression of cirrhosis to compensation to decompensation and acute decompensation. And elevated levels of RIPK3 can predict progression to ACLF. However, in a given individual with acute decompensation, a particular form of cell death may predominate. And these forms of cell death with degree and severity can be associated with different clinical phenotypes. There is an unmet need for integrating the biology with our clinical scores, and we need to identify patients for personalized therapy. And lastly, we need to answer whether these cell death forms are liver in origin. So this study was planned as a multi-center prospective cohort study, including 577 patients. Derivation cohort and validation cohort 2 and 3 were from PGI, which were temporally distinct. Cohort 1 validation was from UCL London and 4 from Berlin, which included the histology data. We recruited patients with acute decompensation and ACLF as per INASL criteria and excluded patients on immunosuppression or HCC or on experimental therapies such as plasma exchange. Data was collected at baseline and day 7 at last assessment in derivation cohort, whereas baseline data and final outcomes were collected in validation cohort 1 and 2. In cohort validation 3, we collected dynamic data at day 0 and day 7. And finally, in cohort 4, we collected data including liver biopsy and immunohistochemistry staining in these histology specimens. So standard statistical analysis, descriptives, logistic regression, ROC analysis, and survival analysis was done. ELISA was used to capture these different forms of cell death. Immunohistochemistry was done on histology specimens to capture necroptosis and pyroptotic markers, and key variables were defined as per literature. Looking at the baseline characteristics of these individuals, the derivation cohort and rest of the validation cohorts were predominantly alcohol related, about 40 in age group. ACLF about 70% in the derivation cohort and about 50% in rest of the validation cohort. The median CLIF-OF score was about 10 and the mortality about 50% in the derivation cohort. However, in the validation cohort, the mortality ranged from 8% to 35%. Now, looking at the different forms of cell death across the severity, we could see that the total cell death, which is M65, was highly discriminatory between no ACLF and ACLF, whereas non-apoptotic forms such as RIPK3, MLKL, and gas germin D showed a stepwise increase starting from grade 1 to grade 3 ACLF, with all intergroup comparisons being adjusted being statistically significant. Now, with the increasing number of organ failures, specifically the RIPK3 went up. And if we see the baseline levels of RIPK3 were much lower in patients who had a resolving course. And when we saw that over the time, first 7 days, the RIPK3 levels increased in patients who had a progressive course, and those who resolved had a decreased levels over time. Now, specifically looking at the type of organ failures, the liver and renal organ failure was significantly associated with elevated levels of RIPK3, where rest of the biomarkers were not. Now, looking at the histology, ACLF histology specimens were highly expressing the RIPK and the gas germin D through immunohistochemistry, whereas apoptotic levels were not different. Now, looking at the marker of mortality, this RIPK3 was 75% accurate in discriminating patients who died. And amongst rest of the markers, if we see, the highest odds of death was linked with RIPK3. Now, if we look at the delta change of RIPK3 over time, the patients who died had a significant increase compared to patients who survived. And then looking at the histology of the patients who died, there was a significant increased expression of RIPK and gas germin D in patients who died, whereas apoptotic levels were not different. Now we derived prediction models, integrating, as I said, clinical scores with RIPK3, and integrating that model, we could identify that it was 84% accurate. AUC was 84% in discriminating mortality. And looking at the delta change as a predictor, it was 90% accurate. And this was statistically significant as compared to rest of the markers. We validated these findings in several of our validation cohorts, ranging from cohort 1, 2, and 3. The performance was consistent and ranging from 75 to 79 or 80%. In the different subgroups with or without alcoholic hepatitis, with or without severe acute decompensation, both baseline and dynamic model was consistently performing well in the validation cohorts. Now, looking at the causal inference through Bayesian causal inference, we could identify that RIPK3 was causally linked with a significant strength, about 98%, and different patterns of cell death we could identify if all three forms of cell death, that is apoptosis, pyroptosis, and necroptosis, were elevated. The probability of mortality was close to 94%. And according to the Bradford Hill criteria for causality, it almost met all the criterias, barring the experimentation, which a recent study from Dr. Jalan's group has shown that blocking RIPK3 can, reduce the severity of ACLF. Now, based on these prediction algorithms, we demonstrate that we can classify the patients at high risk at admission, and these patients has very high mortality. Those patients who are at low risk can be looked for gas dermin D levels. If they are high, again they are at high risk of mortality, about 40%. And remaining patients, we can see the RIPK3 levels. If they increase over time, these patients are also at very high risk, and we can target these patients for novel therapies. And finally, I would like to conclude by saying that cell death has been associated with severity, course, and outcomes. Necroptosis is the main force. RIPK3 is the main marker driving, and it is the causal as well. And liver is the main organ of origin. However, this whole study was predominantly because, including patients with alcoholic liver disease, mainly males, and there is an unmet need to do a randomized control trial to find out whether RIPK3 is a therapeutic target. And more assessments of RIPK3 levels before and after 7 days would help us understand the dynamic trajectories of this biomarker as a real biomarker for therapeutic target as well as a prognostic marker. I would like to thank specifically Dr. Jalan, Dr. Cornelius, team PGI led by Dr. Duseja, and all my family colleagues. Thank you very much.
Thank you, Nipun. Very interesting. I have two simple questions. One is which cell death? What are these cells you are assessing for cell death? For example, your RIPK3 would be lipid dependent, which cells, while your gasdermin will give you immune cells. So which cell death are you assessing? And number two, your control is healthy. Maybe you could have improved by taking pure cirrhosis, which is compensated, and then compare with acute decompensation.
Thank you very much for those questions, sir. Regarding the second question, the healthy controls, in a previous study we just published in JHAP, we already took this healthy cohort, compensated, decompensated, and acute decompensation as a comparison over the spectrum of cirrhosis. So this study was specifically focusing on acute decompensated patients and their outcomes, whether RIPK3 and other cell death markers can predict the patient's outcome, and whether we can actually find a subgroup of patients for a targeted personalized therapy. So we have previously shown, therefore, in this study, we have not taken remaining cohorts because that data was presented. The second thing, the first question was regarding the
types of cell, which cell type?
Which cell type? So basically, through these liquid markers of cell death, we are measuring all forms of cell death, especially necroptosis through these two markers, RIPK3 and MLKL. Gasdermin D, we are measuring the pyroptosis. M30, we are measuring the apoptosis, and M65, we are measuring the total cell death.
Yeah, but they would include immune cells as well as others, like RIPK3 will invite, your myeloid-derived suppressors and others. So they'll be targeting. That's a natural phenomena. But I still feel that taking cirrhosis as a control, with cirrhosis and AD, may improve your, rationale.
Okay.
Thank you.
My question is, if the stimuli for injury is the same, so what derives the particular type of cell death, apoptosis versus necrosis versus pyroptosis? If it's the same microenvironment, why should it be different?
So we did this analysis, an exploratory analysis, whether a particular acute precipitant can change our levels of cell death. So the answer is yes. The infected patients have very higher levels of gasdermin D, and it's And if you see how pyroptosis work, pyroptosis is triggered by LPS or bacterial or pathogen-associated molecular patterns by canonical or non-canonical pathway. Through non-canonical pathway directly activating space 5, 4 or 5, and canonical pathway NLRP3 inflammasome. So pathogen-associated inflammation is likely to be very high gas dermin D, but also there was higher RIPK3 levels, and all our models performed really well in patients who were infected compared to patients who were in alcoholic hepatitis, compared to patients without alcoholic hepatitis. So all were ALD cirrhosis. The acute triggers could be acute upper GI bleed, infection, or alcoholic hepatitis plus infection, right? So
Very brief,
yeah,
please. We
sorry.
have
So there were
overshot.
differences, yes.
And secondly,
Quick,
irrespective of what is happening, ultimately
we
liver is
are
getting injured. So is it possible that the conventional MELD score or a delta MELD would have given the same answer?
So we have combined delta MELD with biological these markers, and we have found that it is an additive.
short
90%
question,
accuracy.
short answer, please. We are out of time.
Nipun, very good question, very good work. I just wanted to know first, you selected RIPK3. RIPK3 is the receptor protein kinase. So did you check the phosphorylation status of the protein? Because expression does not mean that the receptor is activated. And you can very easily use IL-1 beta or IL-6, which is a downstream signaling for RIPK3 activation 40. The other part is, as it is a receptor, it may not come into the circulation, making this identification on the biopsies or on the cells. But if you can do IL-1 beta or something which may correlate very well and come into the circulation, would be a nice biomarker downstream of RIPK3. The other part, as sir said, that which kind of cells are you targeting and which kind of cells you were focusing on, as you showed in the liver biopsy the expression of RIPK3, but did you check the expressions on the cells and the circulating cells, and which kind of cells, neutrophils, monocytes, which kind of cells are you targeting? So these are two questions.
Let me clarify the questions first. The first question is regarding the phosphorylation of RIPK3 and whether you have measured that. So we have measured and second, integrating the second, we have measured the liquid biomarker as a plasma level. So it is not specifically cell-bound RIPK3 which we have measured in the plasma. Whereas in the histology, we have done an immunohistochemistry staining for RIPK3. So normally if you see the biology, RIPK3 is normally physiological states not expressed inside the liver. So when the necroptotic forms are activated, and why they are activated? Because apoptosis becomes overwhelming. In mouse models, they have shown if caspase
We'll have to
8 is
stop,
knocked
Nipun, and I apologize to others because we are running out of time.
So we can
Sorry,
just-
Rakesh and the other speaker. Thank you, Nipun.
Thank you, sir.
In future also, I think short questions and short answers. Very quickly. You to invite.
The next paper is by Dr. Divakar.
Divya P. Kumar.
Okay. Divya Kumar, and she's going to talk to us on the role of AATF silencing in shaping tumor microenvironment molecular signatures in hepatocellular carcinoma. Divya.
Good morning, everyone. Thank you to the Scientific Committee of INASL for selecting our research paper to present in the plenary session. So today I'll be talking about how silencing AATF will remodel the tumor microenvironment, affecting the tumor progression in hepatocellular carcinoma. So understanding that this crowd doesn't need an introduction or a background on hepatocellular carcinoma and the importance of the role of molecular targeted therapies in the treatment of HCC, I will pitch in directly to the rationale of our work. We found that AATF was upregulated in hepatocellular carcinoma. Initially, we tested them on the human HCC cell lines. We found that AATF was upregulated. Then we procured human HCC tissues from NTTR Mumbai and checked the expression. In order to increase the sample size, we collected the data sets from TCGA and found that AATF was upregulated in HCC. The expression was positively correlated with the stages of HCC and tumor grade. Knowing that the AATF was upregulated in HCC, we elucidated the molecular mechanism mediated in AATF-mediated angiogenesis in human SCC, got the paper published. With this rationale, the next question what we had, based on the pilot study we conducted, using an orthotrophic xenograft model of HCC, was that we found the expression of AATF to be upregulated both in tumor microenvironment as well as the tumor. So the next question was, if we silence AATF in a tumor microenvironment, what would that effect have on the tumor progression in HCC? So for this, the best experiment model we could think of is orthotrophic xenograft model of HCC. Here what we do is we take the human HCC cells and inoculate them into the liver of mouse surgically and then allow it to grow for 2 weeks. Once we confirm the development of the tumor, we silenced mouse AATF. I reiterate, we silenced mouse AATF. In this experiment, the mouse liver will be serving as the tumor microenvironment for the developing human SCC cells. So we silence the mouse AATF, and it is very liver specific, where we used AAV8 with TBG promoter. Upon the completion of the experiment, we euthanize the mice and carry out the histological, biochemical, and molecular analysis. So with the allotted time limit of 9 minutes, I would be only presenting the key results. As hypothesized, we found that upon silencing AATF, there was a reduction in tumor weight and tumor volume. And then we wanted to confirm the experiment. Was the AATF downregulated only in the TME? Yes, the expression of AATF was downregulated only in the TME of the AATF silenced mice, but not in the tumor. Confirming this, it was very clear to us that silencing hepatic AATF in the tumor microenvironment suppressed the tumor progression in the orthotrophic xenograft model of HCC. So further on, we did a transcriptomic workflow where we did an mRNA sequencing as well as long non-coding RNA sequencing. The workflow was very clear that we wanted to separate the mouse genome versus the human genome and then mapped against individually the mouse and the human genes, did a differential gene expression. We also validated the transcriptomic data on bench using either qRT-PCR, Western blot, immunohistochemistry, as well as ELISA. So moving on to the result, before moving into the transcriptional analysis, what is important is to make sure there's a distinct separation between the groups, that is the SI control group versus the SI-AATF group. As you see, there is a distinct separation. And then we also want to make sure there is no sample variation within the group, which is also very clear. So we confirm this both in the tumor microenvironment as well as the tumor. When I say tumor microenvironment, it is the mouse liver tissue versus the tumor, which is the HCC, human HCC cells. Confirming that the data is very clean and clear, we further analyze the differential gene expression. As you are aware, tumor microenvironment is very dynamic and complex, consisting of various cellular components with high signaling pathways. When we silenced AATF, we saw that there was reduction or downregulation of key signature molecule in the tumor microenvironment. We found that there was a reduction in the immune response, inflammation, when we silenced AATF in the tumor microenvironment. Consistently, we found that there was a reduction in tumor angiogenesis, extracellular matrix remodeling, and interestingly, the epithelial mesenchymal transition also reduced when we silenced AATF in the tumor microenvironment. As you see, E-cadherin expression was high, meaning that the epithelial did not transition to mesenchymal. Vimentin is low, which is a marker for the mesenchymal transmission. TGF-beta was low. So this was supported by the key signaling pathway, which got reduced upon AATF signaling, which is when TGF-beta, head, jock, and notch, which are critically important for the HCC development. So this was the transcriptomic data which we saw in the tumor microenvironment. So we were interested to see what is happening in the tumor transcriptomics. Interestingly, we saw that the cell cycle regulation as well as cellular stress response were downregulated in the tumor, supporting our hypothesis. So it was very clear from this data that there's a crosstalk that is happening between the tumor and the tumor microenvironment. So how is this crosstalk happening? Is it the direct regulation of AATF with TGF-beta, or anything else is operating in between? Doing a co-expression network analysis, we found that there's a strong TGF-beta networking operating here. And we found that experimentally, we also validated it. and found that TGF beta signaling is the one which is inhibited when we silence AATF. So is AATF directly acting on the TGF beta signaling? So that question was answered by doing a co-expression analysis of long non-coding RNA and mRNA, which shows a positive correlation that downregulated TME-related pathways. With series of experiments and bioinformatical analysis, we found that there was a long non-coding RNA called MIR100HG, which was responsible for the downregulation of TGF-beta signaling when we silenced AATF in the tumor microenvironment. So to summarize and keep the long story short, what is the mechanism that is actually operating when we silence AATF in the tumor microenvironment? We silence AATF in the mouse tissue, which is the tumor microenvironment, supporting the human HCC cells in the orthotrophic xenograft model. This resulted in the downregulation of a long non-coding RNA, which is MIR100HG, leading to the downregulation of TGF-beta signaling. So how does that happen? AATF interacts with STAT3, and we found that there is a binding site for STAT3 on the long non-coding RNA. MIR100HG, which is a long non-coding RNA, is important for the stabilization of TGF-beta mRNA. So when the MIR100HG is downregulated, obviously it leads to the destabilization of MIR100HT and directly leading to the synthesis, downregulation of TGF-beta protein synthesis. When the TGF-beta synthesis is low, that downregulates the downstream pathways of TGF-beta signaling. Both the canonical pathway as well as the non-canonical pathway was included. And then we did an analysis where we show that silencing AATF in the tumor microenvironment is downregulating the TGF-beta signaling via the long non-coding RNA MIR100HG. So with the downregulation of TGF-beta signaling, we saw a clear indication that the TME signatures were downregulated. So these results gave us a complete idea of how silencing AATF in the tumor microenvironment would lead to the reduction of tumor in hepatocellular carcinoma, emphasizing or highlighting the role of AATF as a regulator in hepatocellular carcinoma, and also providing a strong evidence that AATF can be a therapeutic target for the treatment of HCC. Thank you so much for your attention.
This is a very nice work, Divya.
Thank you, sir.
While they are taking, I have two conceptual questions. One is your xenograft, and you try to separate xenograft from the HCC cell lines. I'm not sure how reflective it is of the real HCC. Part two is that my understanding is TGF-beta downregulation should increase tumor rather than decrease because you have no microenvironment around. So conceptually, TGF-beta is allowing the ECM to propagate. So how are you connecting it to the tumor suppression?
So the logical reason of choosing this orthotrophic xenograft model is we could mimic the tumor microenvironment, but if you take an actual setting, it is very difficult to delineate the tumor microenvironment versus the tumor. So we wanted to see which pathway is activated. So here in the tumor microenvironment, the TGF-beta signaling is downregulated. So that is leading to the crosstalk that is happening between the tumor microenvironment versus the HCC cells.
In the xenograft, there is hardly ECM. It's all tumor.
We are collecting the tumor environment of the mouse tissue.
Yeah, but there is hardly, this all HCC. There is nothing as the ECM in the xenograft. So in the real life, the ECM in the liver is different than the xenograft ECM.
What Professor Sareen is telling in real life scenario,
yes,
you see the extracellular matrix and remodeling of matrix is always associated with occurrence of tumor,
yes,
which is primarily responsible for change in tumor microenvironment. And in models, the extracellular matrix, right, changes has not been demonstrated by you. So that's his question.
So the extracellular modeling,
if you are decreasing right TGF-beta, it decreases cell proliferation in general, even the immune system.
That's right.
Right, even the fibrosis and cell proliferation. It's a multiple effect, TGF-beta.
I agree.
So that's what he's asking the question exactly.
So instead of directly targeting AATF in the tumor, which would obviously downregulate, we wanted to see how would the impact of tumor environment be on the tumor. That was the actual hypothesis of working.
Nice work, Divya.
Two quick questions. One, since it's a transcription factor, have you noticed any changes during the progression of HCC?
Yes, we see that it is positively correlated with the SCC stage as well as the tumor grade.
And the second question, is the silencing affecting any immune cells in the microenvironment? And which immune cells and what is the effect?
We didn't deep dive into the immune cells, but since we used an athymic nude mice, which is only effective on the T cell development, the innate immunity is still active. So we see that innate immunity has been inhibited by the silencing of AATF.
Hi, Divya. Nice question. So, your work essentially proposes AATF as a therapeutic target in HCC, right?
Yes.
Have you checked what the tissue specificity or HCC specificity of AATF is? Because it seems to be a transcription factor involved in multiple
Yes.
downstream gene regulation. And what would be the impact of AATF inhibition in other tissue types?
So far, the ATF expression is done in breast cancer, colon cancer, and lung cancer. The trigger for the increase in ATF expression is the inflammation, which we have found out the TNF alpha is leading to the increased expression of ATF. So it's more tissue specific, yes.
It
At
is
least-
tissue
yes.
specific. Okay. Thank you.
Hello, Dr. Divya. Very nice presentation. I have a very small and very simple question. AATF is a transcription factor. So you linked AATF with the long non-coding RNA, and that was very good, mir RNA. But one thing is that did you check that that AATF actually sits on the long non-coding area and actually transcribes the RNA,
No,
or
it-
it is just an effect that is you are seeing in this? And the second very important question is that as it is called as the apoptosis associated transcription factor, so it means that it will activate TGF beta as Sir said, not dysregulate, because when there is more cell death, TGF beta will come up and there would be more ECM production and other things. So this was a little difficult to reconcile, but rest everything.
Okay. So with the AATF, if you can reiterate the first question, please.
Did
He is
you
telling
check-
AATF silencing will upregulate TGF beta.
The first question is, sir, that the AATF is a transcription factor, so it binds
No,
on
no,
the DNA.
AATF is a transcription factor. It doesn't bind directly to MIR100HG long non-codic RNA. It interacts with another STAT3. So through
Yeah, but-
JASPER, we could find out that MIR100HG has a binding site for STAT3. So the interaction of AATF with STAT3 would lead to the downregulation of the long
But did
non-coding
you
RNA.
check whether there is a sequence for which AATF could bind and is present in the
Okay,
long non-coding?
okay, that's a discussion we can take on later on. Right, there is a basic question.
Hi Divya, very nice talk. I'm here. So I have one question. The xenograph that you have used, is it viral based HCC or non-viral based HCC?
It's a human HCC cell line that we have inoculated into the athymic nude mice liver.
Okay, okay.
It's not viral.
Okay. And the other question is related to the first question that was asked. Since you have clearly shown downregulation of the TGF beta pathway and remodeling of the extracellular matrix in the mouse, so did you find the shift of any immune contexture in the tumor structure among the silenced?
We didn't deep dive into the immune modulation as such. What would I anticipate is we didn't check whether there would be a shift in the macrophages from M1 to M2, because only the innate immunity would be activated in this type of model.
So one suggestion, since you have bulk sequenced the
Yes.
RNA, use that to get an estimate of the immune cell population.
Okay, yes.
It gives a very
Yes, we'll do
accurate
that.
estimation.
Yeah, thank you
Thank
so
you.
much. Thank you.
Thank you very much.
May I now invite Dr. Sagnik Biswas to present the last paper, and that's titled "A Combination of Medical Therapy and Early Endovascular Intervention is Superior to Medical Therapy Alone as the First Step in Management of Primary Budd-Chiari Syndrome, a randomized trial."
Thank you, sir. At the outset, I would like to thank the organizing committee of the INASL for providing the opportunity to present our study. Our study was a randomized controlled trial. It challenges the current dogma of stepwise management of Budd-Chiari syndrome. So the stepwise management was actually proposed based on an observational study in 2006 and proposes that Budd-Chiari syndrome should initially be managed with medical therapy. And the steps are of increasing invasiveness as the disease response is not seen with therapy. However, as was seen in the study in 2006 and subsequently in 2013, the success of the first step was significantly low, just around 17 to 20%, and majority of patients actually required a step up to more invasive therapy. So this stepwise management, which was proposed, had some benefits in terms of a minimally invasive approach and possibly cost-effective, but the downside was that it tried to fit all Budd-Chiari patients into a single algorithm. Whereas now we know that the treatment is actually determined by the vascular anatomy of these patients. Similarly, it did not tell us how long do we wait before we go ahead with the intervention in these patient groups. And finally, the treatment outcome, the clinical outcome was dependent on the development of portal hypertension related symptoms, which is new onset or ascites or rebleeding. And in the current era, I don't think that we should wait for portal hypertension to develop, rather prevent its occurrence. So our hypothesis was that an early endovascular intervention guided by the vascular anatomy of the patient along with medical therapy would be superior to medical therapy alone as the first step in Budd-Chiari syndrome. The study was a superiority design. We took the estimates from the study by Plessier, Sejo, and a subsequent study by Professor Epen, which was on early endovascular therapy. The sample size was quite low, it was just 30 patients. However, in order to increase the power of our study, we continued recruitment beyond the sample size once it was achieved. This was our overall study outline. We took patients with primary Budd-Chiari syndrome. They underwent a baseline evaluation and they were subsequently randomized. In group 1, they received early endovascular intervention based on anatomy along with standard medical therapy, and in group 2, they received standard medical therapy as advocated by the INASL guidelines. The assessment was monthly, clinical, along with ultrasound of abdomen. We assessed all complications related with both medical therapy as well as the procedure arm, and did liver stiffness measurement, which is a modification since most of our patients had ascites, to assess rates of hepatic decongestion. And we assessed clinical response at 12 weeks. So this time point of 12 weeks is actually highly debated. The PASL guidelines actually advocate assessment at 8 weeks. However, the same guidelines also mention that there are a certain group of patients who are late responders. So in order to account for that, we took an additional 4 weeks. Standard study definitions were used for Budd-Chiari syndrome. And for vascular anatomy, short segment disease was allotted to patients who had a length of obstruction less than 4 centimeters, long segment more than 4 centimeters, and diffuse hepatic involvement was patients who had multiple small hepatic veins involved instead of a single large vein. We used a modification of the INASL 2016 guidelines to define clinical response in our study, which was mainly resolution of ascites, decline in serum bilirubin, absence of first or recurrent events associated with portal hypertension, and absence of SBP. The two criteria which we took out was the BMI criteria, because some of our patients are malnourished and a BMI cutoff of 20 was never validated. And the other one which we took out was factor 5 levels, which is not routinely available in our country, and it was used in the initial guidelines because INR was not available at the time. Complete response was defined if patients satisfied all of the criteria, and partial if patients satisfied some of the criteria outlined here. These were our inclusion criteria, mainly adult patients with symptomatic BCS. We excluded ACLF, ALF, pregnancy, and other standard exclusions. This was the overall protocol for intervention, where patients with combined block, if we could reconstruct the hepatic vein, they went ahead with angioplasty and stenting. For patients who where we could not reconstruct it, we attempted an IVC angioplasty with a TIPS. And for isolated hepatic vein obstruction, short segment was treated with stent placement and long segment with TIPS. Our outcome measure was the comparison of complete clinical response. Secondary measures were the changes in severity of illness scores, child and MELD, and the change in liver stiffness. Standard statistical tests were used for the analysis. So this is our overall cohort. We screened 80 patients. We were able to enroll 44. 23 received medical therapy alone. 21 received endovascular interventions. All patients were followed up for 12 weeks. Among endovascular interventions, similar to what was reported in the Western studies, TIPS was the most commonly used endovascular intervention. In patient characteristics, the MELD scores were comparable, around 14. The Rotterdam score was 1. Most of the patients belonged to child class 1. In symptomatology, majority of the patients had ascites followed by abdominal pain. Hypercoagulable state, it was identified only in 14 patients out of 44, that's roughly 30%, and the most common was an isolated protein C deficiency. Coming to vascular anatomy, we found that patients who had isolated hepatic vein involvement were more common in our cohort as compared to a combined obstruction, but majority had a long segment occlusion in our study group. So coming to the outcomes at 12 weeks, our primary response was achieving complete clinical response. We found that patients who underwent endovascular intervention significantly outperformed patients who were on medical therapy alone. However, we did not observe a difference in the child and MELD scores, probably because the duration of wait, which was 12 weeks, was probably too less to observe a major change in these factors. We also noted a significant decline in the liver stiffness measurements, and I will show you in a subsequent graph as well. And an important difference which we noted, this did not achieve statistical significance, but it was of clinical relevance that while on the waiting list, while patients were awaiting in the SMT arm, we had 3 mortalities as compared to none in patients who received endovascular interventions. So this is the overall graph which shows the change in LSM. And an important thing to note here is while the LSM declined in both groups, they did not reach normal in either of the 2 groups, which means that there is some underlying fibrosis in these patients which the endovascular interventions are not able to correct. What we have observed here as a decline in LSM is just change in hepatic congestion. Coming to adverse effects, there were 2 adverse effects which were more than grade 3 in our study group. One was a TIPS restenosis, which required further intervention, and one was the occurrence of hepatic encephalopathy of grade 2 in 2 patients, both of which were managed medically. They did not require any reduction in stent diameter. And in a post-hoc analysis to assess whether medical therapy can be used in any subgroup of patients, we found that all 4 patients who demonstrated a clinical response actually had a short segment obstruction. Patients with long segment obstructions do not respond to medical therapy at all. So coming to the discussion portion, we found that early endovascular interventions were associated with higher rates of complete clinical response, did have greater rates of hepatic decongestion, and were associated with a non-significant reduction in mortality, which is clinically relevant to our study. Medical therapy, it works in a subgroup of patients who have short segment disease and may be used in patients who are unwilling for intervention at the outset. The limitations of our study, since it is Budd-Chiari syndrome, the patients were difficult to recruit. There will always be a sparse data bias because of that. The time point of response, 12 weeks, was empirically chosen. We could have performed the interventions earlier at 8 weeks, and the interventions were a mixed bag. We had hepatic vein stenting along with TIPS, which may have a different outcome, since one is a revascularization procedure and the other is a decompression procedure. However, it does provide real-world guidance because in clinical practice, interventions are decided by anatomy and not just a fixed algorithm. So in conclusion, early endovascular interventions guided by vascular anatomy should be considered in patients who have symptomatic primary Budd-Chiari syndrome. They help in reducing hepatic decongestion and increase the rates of early complete clinical response. This is the algorithm which our study proposes. For asymptomatic patients, we can consider a trial of medical therapy or stepwise since they do not have symptoms. For long segment disease, we should ideally pursue an early endovascular intervention, while for short segment obstruction, some patients may respond to medical therapy. However, how to identify that group of patients still remains unknown and needs further evaluation. However, majority require an early endovascular intervention. Thank you.
Dr. Biswas, while we wait for others, did I get it right that you presumed for sample size calculation that one group would have a 17% response rate and the other 70%?
Yes, sir.
Would you then think that there was equipoise?
Sir, so ideally, when there is such a stark difference in the effect size, a randomized trial is not required. But the current guidelines, despite the availability of this evidence for the past 16 to 18 years, do not reflect that change. And they still advocate stepwise management. Only the recent APASL guidelines have suggested a change that we should do endovascular interventions upfront.
But do you think doing such a RCT was right when there are multiple studies, including your own center studies?
Yes, sir.
Showing long-term benefit also TIPS and showing survival benefit.
Yes, sir.
Improvement in liver score benefit. Already you have documented that. And
sir, so majority of these studies were observational in nature, sir, which have certain biases and confounders regarding lack of data, regarding the patient selection. We just wanted to eliminate that with an RCT, which would provide clear-cut,
this has strengthened the evidence much more strong.
Yes, sir. Wow. We now have an RCT which supports this approach.
Dr. Mishra, please.
So, Agnik,
sir.
Decompression is better or revascularization is better?
Sir,
even in EHO now they say that you should do a revascularization.
So that is an ongoing debate whether revascularization versus decompression.
No, your hunch.
Because sir, if the patient is not cirrhotic, I would prefer revascularization since it restores physiological flow. But if the patient is cirrhotic and prone to decompensating events, I would prefer decompression. In our study, I did not show this data. So the median time to delay in diagnosis of Budd-Chiari was over 1 year. Majority of our patients were
That's
cirrhotic.
the reason that 2 of your patients developed hepatic encephalopathy.
Yes, sir. Yes, sir.
Yeah, nice presentation.
Thank you, sir.
The etiology of Budd-Chiari was possibly chronic in majority of the patients.
Yes, sir.
So that means by the time they had presented, they had already had fibrosis rather than thrombosis alone.
Yes, sir.
So how do you go with the premise that anticoagulants will help? You already have fibrosis, so
Yes,
by default you will need some sort of decompression.
Yes, sir.
So medical therapy shouldn't be acting at all after 1 year.
Sir, so that was...
It is useful only in the first 2 weeks of acute thrombosis.
Yes, sir.
Short of that, everybody would need an intervention.
So that was one of the limitations of the 2006 proposal, that they did not consider the status of underlying liver disease and fibrosis before making the recommendations, which are now being followed. Just highlights that we have to look out for liver fibrosis before choosing the intervention.
Because the standard medical therapy differs from acute, subacute, and then chronic. That's a very relevant point which he has
Yes,
mentioned.
sir. So that is why
these appear to be chronic only.
Sir, so that is why we excluded acute patients, sir, because for an acute block, I would go ahead with an endovascular intervention and establish blood flow acutely in these patients.
Dr. Roy.
Sir.
Great, again, challenging common practice. 2 questions.
Thank you,
Given the background literature, did you have a priori termination exposure that given the outcomes being so different,
yes, sir.
Could you have just terminated it before seeing what the differences are? And secondly, about the LSM,
yes,
it's measured by the FibroScan machine,
yes,
that's the EcoSense machine.
Yes, sir.
So do you think that's valid given the problems of EcoSense when you've got a majority of patients with ascites?
Right.
Or would it vary if you're using an ultrasound-based LSM measurement?
Right. So for the first question, the sample size at 30 did show a significant difference. However, there are issues with such a small sample size. It is prone to small data bias. So we wanted to increase our size to increase the reliability of our results. The second was regarding the LSM. There are established methods for doing LSM in ascites. What we did was a large volume paracentesis and turned the patient to the left lateral position, identified an area of the liver which was not covered with fluid, and used with an ultrasound, and then did fibroscan from that area. And this was done uniformly for all patients.
I think Dr. Biswas.
Thank you, sir.
Since most of our Budd-Chiaris are idiopathic, anticoagulation probably doesn't work and shouldn't be the first line of therapy.
Yes,
your main takeaway is that endovascular intervention with anticoagulation
should be the first step, sir.
Yeah, okay.
Thank you, Dr. Biswas. On behalf of all the chairpersons, I thank all the speakers and the audience. Thank you.
Thank you very much.